Welcome to the Creative Commons RX podcast. Before diving into this episode, I want to ensure we're all on the same page. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this podcast is at the user's risk. The content on this podcast is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice from any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. Notebook LM, a Google AI tool, created the audio content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.
Okay, let's unpack this. We're diving deep today into a medical emergency that, well, nobody ever wants to witness, but understanding it is absolutely critical. Adult cardiac arrest resuscitation.
That's right. Cardiac arrest is a sudden, really life-threatening event. And while we've learned so much, it remains a huge challenge.
Right.
Outcomes are often poor, which is exactly why, every single step in the response matters so much.
And we've got a stack of notes here covering the whole picture, from the fundamental ABCs you might learn in a basic class, all the way through the complex treatments in an intensive care unit, and even what happens after someone survives.
Yeah, our mission today is to walk you through that journey. We want to distill the essential knowledge, highlight some maybe surprising facts, and really make it clear how this intricate process of bringing someone back from the brink actually works.
It feels incredibly complex, but there's a system, right? A framework that everyone involved relies on. So let's start with the absolute basics. What exactly is cardiac arrest?
At its core, cardiac arrest is when the heart suddenly and unexpectedly stops pumping blood effectively. More formally, we define it as the absence of signs of circulation.
Absence of signs of circulation. Okay, and what does that look like to someone, witnessing it?
Clinically, if you see someone suddenly collapse and they are unresponsive, they're not breathing normally, maybe they're gasping, or not breathing at all and you can't find a pulse, those are the classic signs.
Right.
That's the moment you suspect cardiac arrest.
That immediate recognition is so crucial, isn't it? Because you mentioned this is a massive problem. Give us a sense of the scale.
It truly is. In the United States alone, emergency medical services, EMS, respond to over 340,000 out-of-hospital cardiac arrests, OHCAs, every single year.
Wow. 340,000 just out of hospital.
Just the ones EMS treats. When you include cardiac arrests that happen inside hospitals, the total estimate is over 600,000 annually.
Over 500,000 times a year, someone's heart suddenly stops. That's staggering. And where do most of these happen?
Here's a crucial statistic. About 70% of EMS-treated OHCAs occur at home.
70%. At home?
Yeah. This isn't just happening in public places. It's in living rooms, bedrooms, around dinner tables.
So it's highly likely that if you witness a cardiac arrest, it could be a family member or a friend.
Exactly. And that highlights another key challenge. Around half of these arrests are unwitnessed.
Meaning no one saw it happen.
Right. No one was there when it happened. And even when someone is there, bystander CPR rates are still relatively low, averaging around 40%.
40%, that seems low.
It is. That's a huge area where potential intervention is missed.
And the heart's electrical rhythm at the moment of arrest matters too. You mentioned that.
It matters a lot. Historically, many arrests started with a shockable rhythm, like ventricular fibrillation, VF, or pulsus ventricular tachycardia, PVT.
Those are the ones a defibrillator can help with.
Exactly. These are chaotic electrical activities where the heart is kind of quivering instead of beating, often linked to primary heart problems like coronary artery disease. Defibrillation, a shock, can potentially fix these. But we've seen a trend. The proportion of EMS-treated OHCAs presenting with a shockable rhythm has actually declined over time. It's now around 18%.
18%. So most out-of-hospital arrests are now non-shockable rhythms.
Correct. Rhythms like a systole, a flatline, or pulseless electrical activity, PEA.
What's PEA again?
With PEA, there's electrical activity on the monitor, but the heart isn't pumping effectively, or sometimes, not at all. These non-shockable rhythms often point to non-cardiac causes, like severe respiratory issues or maybe a massive clot in the lungs, and generally have a much worse prognosis.
Okay. Given all these factors, the high incidence, often unwitnessed, low bystander CPR, more non-shockable rhythms, What do the overall survival numbers look like? Are they getting better?
Well, the outcomes remain challenging despite advancements. Globally, less than 1 in 10 people who suffer an OHCA survive to leave the hospital.
Less than 1 in 10.
For cardiac arrests happening inside the hospital, or IHCA, the survival rate is better, around 1 in 5. U.S. data from a few years ago shows 9% survival for OHCA versus 23% for IHCA.
So being in a hospital when it happens more than doubles your chances.
Roughly, yes. That difference really underscores the importance of faster recognition, immediately available trained personnel, and access to advanced equipment and resources right there.
Makes sense.
But, and this is really important, survival isn't the only measure of success here. Neurological outcome is absolutely critical.
Meaning how well the brain recovers.
Exactly. Post-cardiac arrest brain injury is a major issue, significantly impacting long-term recovery and, well, quality of life. We've seen studies where an intervention might help the heart start beating again, what we call return to spontaneous circulation, or ROSC.
ROSC, okay.
And even get someone to the hospital alive, but it doesn't improve whether they survive with good brain function. That's the big picture challenge we're trying to address.
Okay, so it's a prevalent, often unwitnessed event at home. Outcomes are tough, and protecting the brain is paramount. How do we even begin to tackle something this complex? You mentioned a roadmap.
Yes, that's the chain of survival. It's the universal accepted framework outlining the sequence of actions that, when linked together effectively, give someone the best chance of survival and a good outcome.
Like a game plan.
Yeah, think of it as connecting crucial steps, each one relying on the one before it.
Like the essential links in a chain. If one breaks, the whole thing is compromised.
Exactly. And there are slightly different chains for OHCA and IHCA because the environment is different. The IHCA chain actually starts with early recognition and prevention, identifying patients at risk before they arrest, which isn't usually possible for a sudden OHCA.
Ah, interesting. Okay, so what are the links for, say, an out-of-hospital arrest?
For OHCA, the chain starts with 1. Activation of the emergency response, calling 911 or your local number.
2.
High-quality CPR. 3. Defibrillation using an AED if available.
AED, the box on the wall.
That's the one. Then 4. Advanced resuscitation EMS and paramedics taking over. 5. Post-cardiac arrest care once in the hospital. And the newest, 6. Recovery the long-term journey. Each link is vital.
Let's dig into those first few links, which fall under basic life support, or BLS. This is stuff anyone could potentially do or benefit from.
BLS is the absolute foundation, and bystander BLS is incredibly powerful, especially for OHCA. It starts with that recognition and activation we discussed. Spotting the signs, unresponsive, not breathing normally, no pulse, and immediately calling for help.
The dispatcher can help too, right?
Yeah, the dispatcher can even guide you through the next steps over the phone, which leads right into the next step after calling for help. High-quality CPR.
Okay, tell us about that. High-quality CPR.
Precisely. The purpose of high-quality CPR is to manually pump blood around the body, especially to the brain and the heart muscle itself, to keep those vital organs supplied with oxygen until definitive treatment arrives or the heart restarts. And high quality means following specific standards.
Like what? What makes CPR high quality?
It's about doing chest compressions at the right rate. That's 100 to 120 beats per minute.
Uh-huh. Like the song.
Exactly, like Staying Alive or Another One Bites the Dust, that tempo. The depth should be adequate, at least 5 centimeters, which is about 2 inches for an adult, pushing hard and fast in the center of the chest. Crucially, you need to ensure full chest recoil. Letting the chest come completely back up between compressions allows the heart to fill again.
Okay, recoil. Important.
And you must minimize interruptions to compressions as much as possible. If providing breaths, it's about 10 breaths per minute, but compressions are really the most critical component and should start immediately.
So push hard, push fast, let the chest come all the way up, and don't stop pressing unless absolutely necessary.
That's it. And then early defibrillation.
This is for the shockable rhythms, VF and PVT.
Exactly. If the dispatcher or an automated external defibrillator, an AED, indicates the rhythm is shockable, delivering a shock can potentially reset the heart's electrical activity.
And those AEDs are pretty straightforward.
They are. AEDs are designed for lay rescuers and tell you exactly what to do, with voice prompts. Minimizing pauses and compressions immediately before and after delivering a shock is also key here to maximize the effectiveness of the shock.
So BLS is that crucial initial response. Recognize, call for help, start pushing hard and fast on the chest, and use an AED if available. Building on that is advanced life support, or ALS. This is typically what paramedics and doctors do.
Right. ALS involves more advanced medical interventions. This can include placing advanced airways like breathing tubes, establishing IV or intraosseous IO access for medication.
Oh, into the bone.
Yeah, direct access into the bone marrow, which gets drugs into the bloodstream very quickly when IV access is hard. And a core part of ALS is trying to determine why the cardiac arrest happened in the first place.
Finding the cause seems absolutely vital. Does it really change how you treat it?
Absolutely, especially for those non-shockable rhythms like PEA and asystole. Identifying and treating the underlying cause is often the only path to getting ROSC.
So how do you figure that out during the chaos?
Well, we generally categorize causes into two big groups: primary cardiac issues and non-cardiac issues.
Primary cardiac being problems with the heart itself,
Yeah.
like a heart attack.
Yes, this is the most common cause, especially in OHCA. Coronary artery disease, blocked heart arteries, is often the culprit, frequently leading to VF or PVT. And it's sobering to think that cardiac arrest can sometimes be the very first symptom someone has of underlying heart disease. Other primary cardiac issues include things like weakened heart muscle, cardiomyopathies, or electrical problems.
Okay, and non-cardiac.
Non-cardiac causes are also significant, especially in hospital arrests. These aren't problems that start in the heart, but lead to it stopping. For example, things that stop blood from getting to the heart effectively, like a tension pneumothorax.
That's a collapsed lung that builds up pressure.
Exactly. Air builds up and squeezes the lung and shifts things, putting pressure on the heart, or cardiac tamponade, where fluid builds up around the heart and prevents it from filling. A massive pulmonary embolism, a large blood clot blocking the main artery to the lungs, is another big non-cardiac cause, as is severe blood loss, hypovolemia.
So a clot in the lung, fluid squeezing the heart, or severe bleeding, these aren't heart attacks, but they can stop the heart.
Exactly. Other non-cardiac causes include metabolic problems like dangerously high potassium levels, hyperkalemia, which can really mess with the heart's electrical stability.
Hyperkalemia.
Drug toxicity, especially opioid overdose, which stops breathing and thus oxygen delivery, is another. Severe respiratory failure leading to critically low oxygen levels is also a common non-cardiac cause, as is severe trauma.
It sounds like for those non-shockable rhythms, PEA and asystole, finding and fixing one of these underlying problems is the treatment.
It really is the focus, and medical teams often use a mental checklist or mnemonic to remember these potentially reversible causes during an arrest. It's called the H's and T's.
The H's and T's, what are they? Sounds useful.
They stand for hypovolemia, low blood volume; hypoxia, low oxygen; hydrogen ion acidosis; hyperkalemia, low or high potassium; hypothermia, low body temperature, those are the H's and T's; tension pneumothorax, tamponade cardiac, toxins, poisons, drugs; thrombosis pulmonary, that's the PE; thrombosis coronary, heart attack; and trauma.
Has a lot to remember in a crisis.
It is, but it's a systematic way to think through possibilities. Tools like point-of-care ultrasound or POCS, basically bringing an ultrasound machine to the bedside during the arrest, can sometimes help identify things like tamponade or large PE.
Using ultrasound right there.
Yeah, but you have to be very careful not to interrupt chest compressions for too long while using it. Compressions remain key.
That H's and T's checklist sounds like a critical tool for the ALS team. Okay, we've talked about compressions, shocking, and finding the cause. What about medications during the arrest? This seems like another layer of complexity.
Medications are used to support the core efforts of high-quality CPR and defibrillation. Their main goal, particularly drugs called vasopressors like epinephrine, is to constrict blood vessels to help push blood flow to the heart and brain during chest compressions.
Right, improve pressure.
Exactly. We prefer to give them through an IV or IO line.
Epinephrine is the one everyone's heard of, right? Adrenaline.
Yes, epinephrine is the most commonly used first-line drug in cardiac arrest. For those non-shockable rhythms like PEA or asystole, we give it as soon as possible. For shockable rhythms like VF, it's given after initial attempts at defibrillation haven't worked. Its main benefit comes from its alpha effects, which constrict blood vessels and help increase pressure, hopefully improving blood flow to the vital organs during CPR.
But I feel like there's been a lot of back and forth in the news or research about epinephrine. What's the debate there? Seems like it should just work.
Ugh, this is where it gets really interesting and, a bit controversial. While epinephrine is clearly effective at increasing the chance of getting ROSC, getting the heart to restart its impact on long-term neurological outcomes, is debated and uncertain.
So it helps start the heart, but maybe not the brain. How?
That's the core of the debate. Studies, like the large Paramedic 2 trial, have shown that epinephrine improves survival to hospital discharge, but it did not significantly improve survival with a good neurological function.
Wait, so more people survive, but not necessarily?
That's the finding, yeah. There are concerns that epinephrine's beta effects, which make the heartbeat faster and harder, might actually be detrimental during or after arrest.
Why detrimental?
Some worry it might increase the heart's oxygen demand when blood flow is limited, or potentially affect blood flow in the tiny vessels of the brain after circulation is restored. So while it achieves ROSC, the overall picture for brain function is less clear. Standard dosing is what's recommended. High doses haven't shown benefit and might even be harmful.
Fascinating. And a bit surprising that the main drug isn't a guaranteed win for brain recovery. What about other drugs? Vasopressin. Heard of that one too.
Vasopressin was studied as an alternative to epinephrine because it's a pure vessel constrictor without those stimulating beta effects. However, research hasn't shown it to be better than epinephrine alone, so it's not routinely recommended anymore.
Okay.
There's also been interest in combination therapy, specifically vasopressin, steroids, and epinephrine, often called VSE, particularly for cardiac arrests in the hospital.
VSE. What's the idea there?
The idea is that steroids might help stabilize blood pressure and reduce inflammation after ROSC. Some initial studies were very promising, even suggesting improved survival with good neurological outcome.
But? Sounds like there's a but.
Yeah, but more recent, larger trials like IHCA have shown increased ROSC with VSC, but the long-term outcomes weren't as clear or didn't show the same benefit. So guidelines don't routinely recommend VSC yet due to this conflicting evidence. It's still being looked at.
And antiarrhythmics, like amiodarone or lidocaine, are those used?
Yes, these are used specifically for those shockable rhythms, VF or PVT, that don't stop after initial defibrillation attempts. They help suppress the abnormal electrical activity and try to keep the heart in a stable rhythm.
Do they help?
They've shown some benefit in improving survival to hospital admission and possibly survival to discharge in specific groups like those whose arrest was witnessed by a bystander. So yes, they have a role for refractory VF-PVT.
Are there any other common drugs people might hear about in this context? Calcium, sodium bicarbonate, stuff like that.
This is another key point. Routine use of calcium or sodium bicarbonate during cardiac arrest is generally not recommended.
Not recommended. Why not?
Yeah. They can actually be harmful in many cases. They are reserved for very specific situations where the cause of arrest is known to be, for example, severe hyperkalemia, that high potassium we mentioned where calcium helps stabilize the heart muscle, or certain drug overdoses like tricyclic antidepressants where bicarbonate can help. Magnesium is only used for a specific type of abnormal rhythm called torsade de pointe. Thrombolytics, or clot-busting drugs, are also not routine but might be considered in the extremely rare situation where a massive pulmonary embolism is the confirmed cause of the arrest.
Because the PE is so deadly anyway.
Exactly. The risk of death from the PE arrest outweighs the bleeding risk from the drug in that specific case. And of course, specific antidotes are used if a toxin caused the arrest, like naloxone for opioid overdose.
So epinephrine is the go-to, but many other medications are highly specific to the underlying cause or rhythm and aren't just given routinely. Got it.
Exactly. High-quality CPR and early defibrillation for shockable rhythms are the core. Medications support these efforts or target identified causes.
You mentioned earlier that finding the cause leads to tailored treatments. Are there other special scenarios for cardiac arrest where the approach changes a bit?
Definitely. While the core principles of BLS and ALS apply, the suspected cause or situation might require additional specific interventions. For instance, if the arrest is due to anaphylaxis, a severe allergic reaction immediate, specific administration of epinephrine is even more paramount than usual. Different dose, different route sometimes.
Makes sense for allergy. What else?
Cardiac arrest after heart surgery is unique because it often happens in a highly monitored environment with medical staff right there. Recognition is immediate, and specific causes related to the surgery, like bleeding or a clot, need to be identified fast. Witness VFET after surgery requires immediate defibrillation, sometimes even internal paddles if the chest is open.
Wow. And pregnancy.
For pregnant patients at 20 weeks gestation or more, if ROSC isn't achieved quickly, usually within about 4 minutes, a perimortem cesarean delivery, PMCD, is a critical intervention to consider.
Delivering the baby during the arrest.
Yes. It can dramatically improve the mother's outcome by relieving pressure on major blood vessels, the vena cava and aorta, which improves blood flow back to her heart and makes resuscitation more effective.
That's incredible.
Pulmonary embolism causing arrest is a challenge. Diagnosis during the arrest itself is hard, but if it's strongly suspected or confirmed, as we discussed, thrombolytics might be used despite the risks. And for arrests caused by severe toxic exposures or electrolyte imbalances like hyperkalemia, giving specific antidotes or treatments, calcium, bicarbonate, glucagon, depending on the toxin or electrolyte, is crucial alongside standard resuscitation.
So the foundation is standard care, but you layer on these specific treatments based on why the heart stopped. It's definitely not one size fits all.
Precisely. Tailoring the approach to the suspected etiology is key.
Now, let's say we've gone through BLS and ALS, maybe given meds, found the cause, and the heart starts beating again. We get ROSC. The person isn't out of the woods, are they? There's a whole next phase called post-cardiac arrest care.
Absolutely. This phase is incredibly critical, and it begins immediately after ROSC is achieved. Surviving the arrest itself is just the first step. The real challenge then becomes managing the consequences. Patients enter what's often called the post-cardiac arrest syndrome.
What's that syndrome all about? Sounds serious.
It is. It's a complex injury state that affects the whole body, not just the heart or brain. It results from the lack of blood flow during the arrest and then the sort of reperfusion injury damage caused when blood flow is restored during CPR and after ROSC. It particularly affects the brain and the heart, but can also damage kidneys, lungs, and other organs.
So the goals of post-arrest care are fixing the original cause and supporting all these injured organs.
Exactly. It requires a highly coordinated, multidisciplinary system of care in an intensive care unit. One major component is targeted temperature management, or TTM.
Temperature management.
Right.
We hear a lot about cooling patients.
Yes, it's been extensively studied. For patients who remain unconscious or comatose after getting ROSC, controlling their temperature is recommended. This means aiming for a temperature range between 32 degrees C and 37.5 degrees C for at least 24 hours.
So not necessarily ice cold, but controlled.
Exactly. While some recent trials comparing specific lower temperatures haven't shown a huge difference in outcomes in certain groups, preventing fever or hyperthermia temperatures above normal after cardiac arrest is definitely important and linked to better neurological outcomes. So it's about avoiding heat, even if the exact target temperature is still being refined for different groups.
What about the heart itself after it's just been through that trauma? What happens next?
Cardiovascular care is vital. Since coronary artery disease is such a common cause of OHCA, getting an electrocardiogram and ECG after ROSC is standard. If there are signs of a heart attack on the ECG, or even a very high suspicion of a blocked artery without clear ECG signs, emergent coronary angiography is strongly recommended.
That's going to the cath lab.
Yep. Heading to the cardiac catheterization lab, where doctors look at the heart arteries and can open blockages if needed. Early angiography is linked to better survival and outcomes.
And the brain injury. You mentioned that's the big concern. How is that managed in the ICU?
Hypoxic ischemic brain injury, damage from lack of oxygen, is the major concern determining long-term function. Protecting the brain involves managing oxygen and carbon dioxide levels very carefully, keeping oxygen saturation between 92-98% and CO2 between 35-45 millimilli-Hg.
Not too high, not too low.
Exactly. Importantly, avoiding too much oxygen, hyperoxia, is also critical as it can be harmful. Assessing the long-term neurological prognosis needs to be done very carefully, using multiple factors over time. It's crucial to delay prognostication, making predictions, until sedating medications are completely out of the patient's system and they are medically stable.
Why the delay?
Because sedatives can mimic signs of severe brain injury. You need to give the brain time. Routine prophylactic use of seizure medications is not recommended unless the patient actually has seizures, which are then treated aggressively.
So support the brain, manage its oxygen and CO2, and be patient with prognosis.
Yes. And then there's general critical care managing blood pressure to ensure all organs get enough blood flow, aiming for a mean arterial pressure, or MAP, above 65 millimilli-Hg, or systolic blood pressure, SBP, above 90 millimilli-Hg. Glucose levels are controlled per standard ICU protocols, typically aiming between 150-180 milli-GDL. Routine prophylactic antibiotics aren't typically used.
Any really advanced support?
In some severe cases, especially if the heart is very weak after arrest, Mechanical circulatory support, like ECMO or ECPR, which is basically a heart-lung bypass machine used during CPR or after, can be used to help maintain organ perfusion. Its use is increasing, but we still need more robust trials to guide exactly when and in whom it's most beneficial.
So post-arrest care is essentially comprehensive intensive care, focused on keeping all the organs working, especially the brain and heart, and dealing with the fallout from the arrest.
That's a good way to sum it up. It's a complex phase, but absolutely vital to translate getting ROSC into meaningful survival. And then there's that final link in the chain we mentioned earlier.
Recovery. That feels like a relatively new emphasis in the world of cardiac arrest, doesn't it?
It is. It acknowledges that surviving to leave the hospital is not the end of the journey. The recovery is often long-term, involving significant physical, cognitive, emotional, and social challenges for survivors and their families.
It's not just fixed when they leave the hospital door.
Not at all.
Yeah.
Comprehensive discharge planning, rehabilitation, and ongoing support through survivorship plans are now recognized as essential components of care. Even debriefing for the responders and hospital staff involved is part of this phase, recognizing the emotional toll of resuscitation efforts.
So the chain of survival now truly spans the entire experience. From the bystander seeing someone collapse all the way to the survivor's life months or even years later.
That's the goal. And while we've covered the key steps, it's important to remember there are still many areas of uncertainty and ongoing research in cardiac arrest care. Optimal strategies for specific causes, managing complex post-arrest complications, and even much of the critical care management are still evolving or based on best practices extrapolated from other critical illnesses. We need more research.
It's clear it's a dynamic field. So, to recap this deep dive for you listening, cardiac arrest is defined by the absence of circulation. Incredibly common, often happens at home, and despite improving care, outcomes are still poor, with brain injury being a major concern. The chain of survival provides that essential roadmap, starting with bystander recognition and calling for help.
Yeah, and high-quality BLS, focused on effective chest compressions and early defibrillation for shockable rhythms, is the absolute foundation.
Then ALS adds advanced interventions, crucial identification of the underlying cause using tools like the H's and T's checklist and maybe post-CS, and medications like epinephrine, though, as we discussed, there's that ongoing debate about its impact on long-term neurological outcome.
Right. And specific causes like anaphylaxis or PE require tailored treatments. Post-cardiac arrest care is that critical intensive care phase focusing on supporting organs, especially the brain and heart, through things like temperature management and urgent procedures like coronary angiography if needed.
And finally, recovery acknowledges the essential long-term needs of survivors navigating life after this event.
It really highlights how every step, from a bystander's quick action to highly specialized ICU care and long-term support, is interconnected and vital. Your awareness of this process truly matters.
Absolutely. And thinking about that ongoing debate surrounding epinephrine's effect on long-term brain function versus simply restarting the heart and the increasing focus on that recovery phase, doesn't it make you wonder how we as a society and within the medical community should fundamentally define success in resuscitation going forward? Is just getting the heart restarted enough, or is survival with good neurological function the ultimate goal we should be relentlessly striving for? And how should that shift our research priorities and allocation of resources? Something to think about.
A profound question, and one that will definitely continue to shape the future of cardiac arrest care.
This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this podcast is at the user's risk. The content on this podcast is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice from any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. Notebook LM, a Google AI tool, created the audio content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.